because you had two ANDs on Saturday, but one of them is getting shifted. I think Zainab ma'am is not free, so her END is on some other day. So I got an opportunity. So mine will be on Saturday. Just it will get confirmed. So you will get time to revise your ortho and surgery and Saturday के both the ANDs. ठीक है तो अच्छा मौका मिलेगा बड़े बड़े सब्जेक्ट कवर हो जाएंगे. Okay, but they'll confirm on the group, but this is to my knowledge because I have to take it, no? So I was told that mostly it will be on Saturday, most probably, like 90%. Okay, cool. Let's start. Let's start with urology. And in urology, of course, you start first with kidney. These are some of the important topics for NEET, PG, and INI CET. Two or three questions you are going to get. And in the last 2 years, they have asked, it's not in this list, so I will add now. Last 2 years, they are asking a particular topic quite a bit. Do you know which one that is? Very nice, CA penis. So I'm adding it to this list of IMP topics. Okay, so earlier I would not teach CA penis that much because it would never be asked. But last 2 years I have been teaching it because it's coming. So let's start with urology. Let's start with kidney. Little system I have changed. Okay, little order I have changed. So if you are using mission notes or QR notes, थोड़ा order ऊपर नीचे है, but you just need to listen. If you are annotating, then you annotate. Okay, but older notes you just listen. It's all there in the old notes, whichever source you are using. So first, about renal tumors, if they ask you most common malignant renal tumor, it is renal cell carcinoma, also called as Gravit's tumor, adenocarcinoma, also called as hypernephroma. Hypernephroma. Okay, so don't be misguided by this word nephroma because you will think it is benign, but it is not benign, it is malignant. If they ask you most common benign tumor of the kidney, what is the answer? Most common benign tumor of the kidney. Very nice, it is oncocytoma. This is benign. And in radiology, you should know how oncocytoma, how RCC, how Wilms' tumor, and how angiomyolipoma are identified. Okay, in radiology, they all have typical radiological findings. So you must be able to identify them. Now coming to RCC, which is the most common malignant renal tumor. Who gets renal cell carcinoma? Which person is at risk? Anjali Kumari, very nice. This is also seen in elderly males. Smoking is a risk factor. So just like GI tumors, some of the hepatobiliary tumors. This is also seen in elderly smoking males. Another risk factor you can add to it, obesity. Okay, obesity you can add to the list. And there are these four types of RCCs. The most common type is the clear cell type. And if someone has bilateral clear cell RCCs, nobody should have bilateral, but if someone has, you will think about von Hippel-Lindau syndrome, where you get bilateral RCCs. What other tumor is seen in VHL? Yeah, 3p deletion. Very nice. Pheochromocytomas. Correct. Pheochromocytomas are seen in VHL. The other rarer types, one is papillary, which is seen in people who are on hemodialysis. And this papillary RCC shows Samoma bodies, which we saw day before yesterday. Okay, you saw na Samoma bodies in papillary thyroid cancer. Same way, papillary RCC, you will get Samoma bodies. Chromophobe type is the only one which has a good prognosis. And medullary type is seen in children with sickle cell trait. Okay, so these are four straight up MCQs of surgery pathology put together. Okay, sickle cell trait. One option will be sickle cell anemia. That's not correct. It is sickle cell trait. Okay, sickle cell anemia protects you from which illness? Just out of curiosity. Sickle cell anemia, malaria. Why? Why it protects you from malaria? Why? Anyways, now you come to the spread of renal cell carcinoma. Very important. Now, RCC typically arises from the upper pole. Okay, normally upper pole, that's why it's called hypernephromy. And just above the upper pole is the adrenal gland. Okay, and this adrenal gland and the upper pole, they are enclosed in a facial sheath. You know the sheath they are enclosed in. What is this facial sheath called? Gerota, correct? So this is kind of like the capsule of the kidney. So the tumor from the kidney can spread to the adrenal gland via the Gerota's fascia. So adjacent spread is to the ipsilateral adrenal gland, ipsilateral Gerota. But also remember, if the tumor spreads into the renal vein, if the tumor goes from the renal vein directly into the IVC, okay, so invasion of renal vein, invasion of IVC, you will normally think that is metastasis, but it is not. So this kind of a spread, direct thrombic spread, is not metastatic. It is a direct spread. So IVC involvement. Normally you will say IVC involvement means M1. This is not M1. Okay, in fact, this is T3. It is not even M1. IVC involvement is T3, which sounds funny, but it is true. It can go to lymph nodes around the kidney. These lymph nodes, what are they called? What are these lymph nodes called to which the tumor can spread? Very nice, para-aortic. And hematogenously, this is a PYQ, it can cause bilateral lung metastasis, which are called as cannonball lung metastasis. Any other tumor, which gives bilateral cannonball lung metastasis, apart from RCC? Breast, no. Breast, not so common. Testicular tumors. Yes, testicular tumors. Chorizo नहीं, choriocarcinoma. Chorizo कुछ और होता है. Don't say chorizo, that is something else. Okay. Chorizo is a type of meat preparation. I know where your mind is going. Hunger. Yes, yes. But when you write and it auto corrects, don't press enter. No. Don't press enter. You can delete it. Okay. Instead of gadbadi mein gadbadi. Don't do that. Apart from this, RCs, yeah, abdominal lymph nodes are retroperitoneal only. They are retroperitoneal, obviously. Because kidney is retroperitoneal. You know? Apart from this, you get paraneoplastic syndromes. Paraneoplastic simply means it is due to some other hormones or chemicals that the tumor produces, which is seen in some cancers in surgery. Like normally it is seen in lung cancer, small cell lung cancer. That is the common cancer. Apart from it, RCC. So what are the paraneoplastic syndromes? Most commonly, it is going to be raised ESR. Okay, which is actually biochemical. It's not even clinical. You may have increased calcium, hypercalcemia. And this is due to tumor producing PTH-like peptides. Okay, due to PTH-like peptides. In lung cancer, you get Cushing syndrome because of ACTH production or cortisone production. Similarly, here you get hyperparathyroidism. Then there is something called a Stauffer syndrome where the person gets liver derangement. Okay, he gets a liver dysfunction. And it is not due to metastasis. Okay, it is not due to mets. It is due to the tumor producing chemicals like interleukin 6, which causes some hematotoxicity. So basically, if I remove the RCC, the hematotoxicity will go, the liver function will become normal. Polycythemia can also happen because of erythropoietin production. Many types of are possible depending on what chemicals the tumor produces, right? So these are some of the extra findings. Like in stomach, we did those extra findings, Sister-Mary-Joseph nodule, Furcow's node. Same way over here, you have paraneoplastic. Okay. Paraneoplastic syndromes don't affect the TNM stage. Okay, they don't affect TNM. The TNM will remain the same. Okay, So don't say just because he's having liver dysfunction, it is metastasis. No, it should be due to meds, then it is M1. Does RCC spread to liver normally? Does RCC spread to liver? Is it common? No, why? Why not? Why it goes to lungs, not liver? Stomach, colon, rectum went to liver. Yeah, because there was portal vein. This is not going into portal vein. This is going into IVC. IVC, right heart, lungs. That's why lung mets are common in kidney. Liver mets are common in GI cancers. Okay, because it is going via portal vein in GI cancers. Now, what will they tell you when they are telling you RCC? They will say elderly smoker male who comes with a painless, profuse, or gross hematuria. Okay, any elderly male with painless, profuse, or gross hematuria to the point that they will say he passes clots in urine. That means it is a RCC. Okay, there is only one condition where you get painless, profuse hematuria apart from RCC. That is urinary bladder cancer. So these are the two differentials: elderly smoker male with gross hematuria. When you have renal stones, hematuria is not gross. Remember, it is small quantity. Apart from this, he may have a palpable lump. So there may be a flank lump, which is the enlarged kidney. And when it in the late stages, he will have flank pain. Yeah, in stones, it is painful also, correct? Absolutely right. He'll have flank pain. If all these three occur together, it is called as too late triad. Again, I will say too late triad and not too late triangle. Then you will say autocorrect. So don't make me rectify it. You autocorrect it, no? If it is autocorrecting. Autocorrect could be autocorrect chahiye. So the logic is it presents late. Just like GI cancers. By the time person gets hematuria, the tumor would already have metastasized. Like you did in GIT, wherever person has upper GI symptoms, you do endoscopy. Lower GI symptoms, you do stool examination. Then you do colonoscopy. Hepatobiliary, last time we did LFT USG. Here, first step in most of the urinary diseases, most is going to be urine analysis. Okay, so you'll do urine routine microscopy. And you will do some imaging like a USG, ultrasound KUB. In some cases, you can do X-ray also, but most of the time, the urologist will ask for these first. So don't need to merge. Urology means urine routine, USG, KUB. What will you see in urine routine? You will see RBCs or you will see blood. Okay, RBCs, blood. Sometimes you can do a cytology of the urine, where you have to collect urine for 24 hours and then send it for cytological assessment. You may be able to see the tumor cells. USG KUB will show the renal mass. So I know kidney is having some swelling, some growth. In the setting of a profuse hematuria, elderly patient, I will think it's a malignancy. How do I confirm that it's a malignancy? I will do CCT abdomen. And it will show a enhancing renal mass. Enhancing means vascular. And if I see this, I don't need a biopsy. This is the first cancer I'm telling you, no biopsy required for diagnosis. It's an imaging diagnosis. Don't need to do biopsy to prove. Okay, it's not contraindicated. You can do it if you want, but it is not a must. But it's not contraindicated. So CCT will tell you. Liver मैंने बताया नहीं ना, but liver में भी hepatobiliary tumors also you don't need biopsy. But I didn't tell you that. That I was going to put in your END. I didn't tell you hepatobiliary tumors, right? So there also no biopsy, RCC no biopsy. Then you want to look for spread or metastasis. For local spread, you will do MRI of IVC. That is called as MRI IVC venogram. Because I want to look for tumor spread into the renal vein and the IVC. Local spread, so I already see on CT. For distant, I will do PET scan. Right? Just like you did GI tumors. So life becomes easy. After this, you get the TNM stage. You need to know the T stage. All urotumors have a unique T stage. And I will tell you, so it becomes very easy to revise. You can just revise all the urotumors from here. Now, renal tumors, the T1 is not going to be mucosa, submucosa. It will be based on the size. So T1 further divided into T1A, T1B, T1A less than equal to 4 centimeters, T1B more than 4 up to 7 centimeters, T2 more than 7 centimeters, T3 has 3A, 3B, 3C, and I have a feeling they will ask you T3 in MCQ. Okay, predict. They will ask you on T3. T3A invading renal vein. This is not a leak question, this is a prediction. तो ये मत बोलना कि ये AND में आएगा क्या? It's not for END. It's for your future exams. T3B tumor invading IVC up to diaphragm, and T3C IVC above diaphragm. So remember, IVC is T3, which means T4, that is invasion of breach of Gerota's fascia or invading the adrenal gland is T4. Okay. Now, for early tumors, what do you normally do as the treatment for early, like early GI cancer, early breast cancer? What do? You do surgery plus adjuvant chemo. Here you use adjuvant chemo or adjuvant radio or both. What will you use here? Adjuvant chemo or adjuvant radio or both? You'll use neither because both are resistant. Okay, RCC is resistant to both. So fortunately for you, there is only one treatment, that is surgery. So for T1A tumors, you do what is called as partial nephrectomy. Okay, partial nephrectomy is like a wide local excision. It's like wide local excision. Kind of. I mean, it is also called as nephron sparing nephrectomy because you're not removing the full kidney. Also called as nephron sparing. No. HCC is not. HCC is chemosensitive. If it is T1B, which is in between, in that case, you will do a partial or radical. Both options are available. You can do partial also, you can do radical also. A lot of factors to decide, not that important, but you can choose. Like for example, if person has von Hippel-Lindau, he has bilateral RCC. In that case, if you want to save one kidney, you will do partial, because one kidney at least you will save. So at least in one kidney you should do partial. Or person has single kidney and he has a 5, 6, 7 centimeter RCC. In that case, try to save the kidney. So there you will do partial.
Yes.
Of course, if it's more than 7, T2, then you will only do radical nephrectomy.
Yes.
And if it is T3, you will do radical nephrectomy, but you will also remove the tumor thrombus. So whatever is removed apart from the kidney and the lymph nodes, you will also remove the IVC thrombus. So IVC नहीं निकालना है, IVC का thrombus निकालना है. Means don't become so radical, right? No, radical nephrectomy means remove the kidney with the tumor, not both kidneys. Only the kidney with the tumor. Normal kidney you leave. If it is invading Gerota and adrenal, usually it will be metastasized. Usually you will do palliation. Okay, because it can't be downstage, so you will do palliation. T2 में IVC में गया ही नहीं है ना. Pos in T2, it is not in the IVC. In T2, it is only in the kidney. So why will you do IVC embolectomy? No, in VHL, yes. If it is in both kidneys, then you will have to remove both kidneys. Obviously. दोनों में है तो दोनों निकालनी पड़ेंगी ना. No doubt नहीं है. Renal vein removed or not? What does your heart say? Renal vein will you remove or not? If you are removing the kidney, ask your heart. Without asking, obviously, what will the vein do there? I mean, why would you keep it? Lymph nodes that you will remove are going to be these para-aortic lymph nodes. ये वाले para-aortic lymph nodes. Palliation means you can try drugs like sunitinib. Please remember, sunitinib or sorafenib are not for cure. Okay, they are not for cure. They are only for control. Okay, so chemoradiio will not work. You can only do immunotherapy. That's it. Yes, that contraindicated kidney is involved due to meds. Means from one kidney to the other, very far-fetched. Very far-fetched. It means there is no connection between the two kidneys. Normally, no. See, it depends on where the tumor is located. If it is near the upper pole, you will remove the adrenal. Okay. Lower pole tumors, you can leave the adrenal. Upper pole tumors, you have to remove the adrenal. So it depends on the location. But obviously, kidney and lymph nodes are going to be removed. That is the meaning of radical. Right? Okay. Now come to CA prostate. This is also going to be seen in elderly men. Not smoking is not really related, but elderly men. Usually after 65 years of age. Okay. It is the most common malignancy in men after 65. Will patients in T4 require hemodialysis? Again, tumor is in one kidney, other kidney is fine. So you don't have to do hemodialysis. No, दोनों में से एक किडनी तो ठीक है ना, दूसरी किडनी गई पर एक तो ठीक है. Why hemodialysis? Right. Now, what do you need to know about CA prostate? Where does it come from? Little bit about the anatomy. So, very little. Your prostate has two lateral lobes. Okay. Then it has one small anterior lobe. Then here is the prostatic urethra. Okay, I'm showing you a cross section. Then here there is a median lobe, and last में there is a posterior lobe. Okay, last में there is a posterior lobe. These are my lateral lobes. CA prostate arises from the posterior lobe, which is very far from the urethra. So CA prostate, posterior lobe. It is also called as peripheral zone. Okay, it is also called as peripheral zone of McNeil. Because it is so far away, it will not compress the urethra. So person will not have urinary symptoms. At least not early on. He will not have urinary problems. On the other hand, so I'll write here separately, benign enlargement of prostate, which you call as BPH. You call it BPH. This arises from the lateral lobes or even from the median lobe. So it will cause urethral compression early. So this arises from the lateral lobes, which is also called as transitional zone. Because it is coming from the transitional zone, this will cause a early urethral obstruction. That's why benign diseases cause more symptoms of the prostate. Okay, more prostatic symptoms come from benign. Right? So this is the basic pathophysiology that you should know. CA prostate, of course, is an adenocarcinoma. It's a gland, and it will metastasize most commonly if I say lymph nodes and hematogenous. Lymph node here also it will be retroperitoneal nodes like obturator, or pelvic nodes, iliac nodes. But hematogenous is very common and very important. I'm sure you know. It will give lumbar vertebral mets via Bateson's plexus. This is a PYQ. This came in the last FMG exam also. So it goes via the paravertebral Bateson's plexus of veins. Hematogenous to vein se hi jayega. And these metastases are osteoblastic. So usually the person will have no urinary symptoms. So you are supposed to diagnose it on screening, or it will be found incidentally. Urinary symptoms unlikely, very rare. Or you may diagnose him because he is having bone mets. So he may have backache. But the problem is backache everybody has. You must also be having. That does not mean you have bone mets due to CA prostate, right? So person will have lower backache, but that will obviously be ignored. Which is why ideally this is one of the cancers which should be picked up on screening. So all men after 50 years should undergo screening. And how do you screen them? Like if you want to identify, you are supposed to do per rectal exam, in which you will feel a hard prostate. It will be hard nodular prostate, which will tell you, okay, it could be a CA prostate, could be. And you will do a serum PSA, very useful test. In a normal person, it should be less than 3.5. If it is between 3.5 to 10 nanogram per ml, you should have a biopsy. How BPH? BPH will be soft or firm and it will show mobility, means the rectal mucosa will be mobile. It will not be hard and the rectal mucosa is mobile usually. If it is more than 10 to 35, this is suggestive of malignancy. So even an elevated PSA alone tells me it is malignant. Just elevated PSA, even without any PR finding. And of course, if it is more than 35, it means it's a advanced or a metastatic CA prostate. So just see how useful the PSA level is to tell you about the stage of the disease. You can even rule it out. Normal PSA and a impalpable prostate on per rectal exam, you don't need to do anything. You know it is not. There is no screening guideline for it in India. So I won't say annually, but yeah, ideally annually, but there is no screening guideline. Like I can't say, like I said for mammogram, okay, annual screening mammogram after 40, ऐसा कुछ guideline नहीं. So if the person has these findings, if he has these findings, how do you confirm your diagnosis? You have to do a biopsy here. So you are going to do a transrectal ultrasound, TRUS, or a transrectal ultrasound with biopsy. And you are ideally supposed to take 12 biopsies, 12 samples, like 12 o'clock, 1, 2, 3, 4, 5, like that, or 2 at each. So you need 12 biopsies representative, like how you had Seattle biopsy protocol for Barrett's. This is like a biopsy protocol. Can't just do one. You will miss it. But any other reason for doing this 12 pieces? Because here I only want to see adenocarcinoma or no. Now, why am I taking 12 pieces? Heterogeneous. So what? So what? Blind biopsy. Confirmation. One piece is enough, na? Because this will give me a score, which is called as Gleason score. It's a biopsy score. And to get Gleason score, I need so many biopsies because I want to look at how many types of cells are seen, how many morphologies of cells are seen. TRUS is transrectal ultrasound. So ultrasound guided biopsy. ऐसे बाहर से नहीं ले सकते ना prostate की biopsy. So you do transrectally. Once it is confirmed that it's adenocarcinoma, you will do local spread. For local spread, you will do MRI pelvis. Okay. Yeah, the score is needed for prognosis. Yes, it's a prognostic score. Absolutely. It tells you the differentiation of the cancer. For distance spread, you will do PET scan. Okay. So CA prostate patient will not come with symptoms. You have to diagnose him by screening. From surgery, no. From pathology, maybe. Not from surgery. I myself don't know Gleason score. I only know the Gleason score. If it is less than or equal to 6, it is good. I only know this much. Okay. 7 onwards, intermediate and poor. That's what it means. Now you need to decide the treatment based on the stage. Now here also there is a TNM stage, but you only need to know this much, only the T stage, not too many details. Okay, you only need to know what is T1. T1 is incidental, T2 is limited to prostate, T3 is breach of capsule, T4 is adjacent organs. Does this remind you of some other staging you have done? Where T1, T2 is limited to prostate or limited to the organ. T3 is breaching the capsule. T4 is spreading to adjacent organs. No, not breast. It is same like GI cancers. Same to same. GI cancer भी ऐसे ही थे ना. Esophagus, stomach, colon, rectum. T3 was serosa. Serosa क्या है? Capsule ही हुआ ना. T4 was adjacent organs. So it's like GI cancer only. Not very different. The simple part here is you only need to know that treatment is going to be done for T1 and T2 CA prostate. For T1 and T2 CA prostate, the treatment offered, preferred treatment is going to be a radical prostatectomy. Like you did radical nephrectomy, you will do radical prostatectomy. You know what is radical? Remove the tumor, wide excision plus lymph nodes. And here you can give adjuvant chemotherapy. Simple treatment. If it is advanced or if it has spread, in this case, there are things you can use, but there are some unique drugs you can use. So I won't just say radiotherapy, chemotherapy, there are some unique drugs. Here you use what is called as androgen suppression. Because like breast was estrogen dependent, this is testosterone dependent. So here there is a treatment of androgen ablation. Means suppress the testosterone. Here which nodes? Same, pelvic nodes. Nodes in the vicinity of the organ. So for androgen ablation, you can use gonadotropin analogs or LNRH analogs like goserelin or leuprolide. I always say these are drugs you may have heard in infertility in females also. There you use, but you can use it for men with metastatic CA prostate. Other drugs are anti-androgens. No, why do you want to give medical treatment if you can cure the tumor by surgery? Then why do you want to give anti-androgens? Because anti-androgens is not very comfortable for the patient. If he's 55 years old, he will not be accepting of anti-androgen for obvious reasons. It will cause a lot of problems in him because of androgen suppression. So you can give anti-androgens like flutamide, bicalutamide, or you can do androgen ablation surgically. And how do you do it? Surgically, how do you do androgen ablation? It is called castration. So bilateral orchidectomy. So simply put, early CA prostate, surgery chemo, advanced CA prostate, androgen ablation. But it is, yeah, but palliation is a little far-fetched to use. You should not use the word palliation. Okay. It means that is a little stretching it a little too much. But yeah, palliation. But there is one exception here. If person is very old, because 65, 70, he can be 80 years old. If he is more than 70 years old and he has a very early T1 CA prostate and he has a low PSA, means it is not advanced, not metastatic, and his Gleason is low. That's why I told you I know what is low Gleason. and you will tell him, I will do a radical prostatectomy plus adjuvant chemotherapy, he will say no. Okay, he doesn't want it. He'll be like, please relax. Don't be such an aggressive surgeon like how you are all aggressive people. He will not be accepting. I accept your aggression forcibly. Patient will not. Patient will say, get out, which I also should be saying. So in this case, you can tell, okay, nothing to do. We will just follow up. You do surveillance. Every 6 monthly, come for finger. Can't we give radiotherapy? That is the alternate to radical prostatectomy. But in the exam, don't mark that. Okay, that is the alternate to radical prostatectomy. But let that not be the answer. Yeah, low PSA means less than 10. Yeah, that's what it is. सारांश ये सब मैं आपको पहले पढ़ा चुका हूँ. You know all this. You're not a नया student. You're पुराना आदमी. What is the time for surveillance? Time means no, this is correct. Incidentally, after TURP is correct, not after truss. Surveillance 6 months. Okay, right. Every 6 months. Yes. Now, bladder tumors are also, students find it tough to understand, but you will not. Usually in bladder, it is a transitional cell carcinoma, also called as urothelioma. This is also seen in elderly smoker males. So RCC. Why do finger when checking PSA can do the job? जब आप सर्जन बनोगे ना तब आप ये सवाल नहीं पूछोगे. So elderly smoker male. You have to trust either your finger or PSA. Whom will you trust? Both. Because finger is your own, PSA is of the biochemist. Okay, finger is not proof, but PSA is proof. You do both. Okay, so this tumor has a very unique occupational connection. Okay, occupational connection. So certain occupations where you are exposed to chemical carcinogens, if you are working in textile factory, dye factory, where you're exposed to chemical carcinogens like aniline dyes, naphthalene, benzidine, these increase the risk of bladder tumors. And bladder tumors will spread same like other tumors to organs around, so they can spread directly to adjacent organs. Like if it's a male, it will spread to the rectum, bladder ke piche. If it's a female, it will spread to the uterus. You can have lymph node mets, same like prostate, pelvic lymph nodes. You can have hematogenous mets. That is again going to be vertebra. So its metastasis workup is very much like prostate only. But here the person will have symptoms. He will be an elderly smoker male. He will come with a painless, profuse hematuria. Okay, painless, profuse hematuria. The first step here also is going to be urine routine microscopy plus USG KUB. Okay, urine routine microscopy plus USG KUB, which will show tumor in the bladder. It will show a mass. Yeah, there is a urinary tumor marker. It is seen in the urine. That is NMP22. Okay, how do you confirm your diagnosis? Here you will do obviously biopsy via cystoscopy. So this is like GI cancer only. You will do cystoscopy with biopsy. And for staging, local spread, same like prostate. You will do MRI. For distant, you will do PET scan. ठीक है, नॉट सो हार्ड ना। यूएसजी के बाद क्या लिखा है? मास। ऑन यूएसजी यू विल सी द मास, mass will be present. Okay, so very easy to identify bladder tumor. Do the biopsy, it will be transitional cell carcinoma. Spread, MRI, PET scan, sorted. Same like prostate, the pattern of investigation staging is very similar like prostate. Now the tricky part is the treatment. This is the part which people find difficult. But actually it's not, because I will tell you a logic. You understand the logic, you will get all the answers. So I always tell this very simple logic, that what are the layers of the bladder if you go from in to out? What is the innermost layer? Is the mucosa. The second layer is not submucosa. The second layer is called lamina propria. Then you have the muscle, the detrusor muscle. And the last layer after detrusor, this last layer is called adventitia. Serosa is only on the top. Most of the bladder has only adventitia. So these are the layers. So if I say pathological T1, P means pathological. It is going to be invading mucosa. And normally you would have said submucosa. But here you will say lamina propria. Instead of submucosa, say lamina propria. एक ही बात हुई. Pathological T2, invading muscularis. Pathological T3, invading adventitia. T4, invading adjacent organs. है ना? Reminds you of staging like. ये तो esophagus, yes. It is same as C esophagus, same to same. Only there it was submucosa, not lamina propria. So bladder and esophagus same staging. How hard is it? Not really hard. If you can remember, extra point, pathological TA is invading only mucosa, but this is optional. If you can remember, then fine. Okay, so these are the T stagings. Then you have N0, N1, M0, M1. Now, for here the treatment is different for the stages. Okay, it's not the same. And MCU can come on this, that if it is only up to pathological T1, different treatment. Pathological T2, T3, different. And for pathological T4, different. So your treatment is different, which is unique, which is what they ask in the exam. That for TA or T1, how do you treat? Normally, what you would have done, you would have done surgery plus chemo. Normally. Here, the surgery that you are going to do is not a radical surgery because it's very early. You just want to remove the tumor cystoscopically. So you do a cystoscopic removal, which is also called as transurethral resection, BT. Okay, transurethral resection, BT. BT means bladder tumor. Okay, not the BT that you give to people like me, not that BT. This is bladder tumor wala BT. And instead of chemotherapy tablet or chemotherapy IV, you are going to give intravesical chemotherapy. You will give intravesical chemo. बहुत ही important है. You will give either mitomycin or the BCG. Okay. The BCG is not given here. Huh? It's not intradermal BCG. This is intravesical BCG. So what it will do, it will bring the T lymphocytes and that will kill the residual tumor cells. That is the logic. The T cells will come. It is a contact chemo, correct? It is intravesical. Okay. One of the few cancers where you can do this. Not many cancers have contact chemotherapy. This is one of the few cancers. But of course, if it is muscle invading, then you will do like your other GI cancers. Radical cystectomy. And adjuvant chemotherapy. Only once, no. Contact chemo is given in multiple cycles. Yes, multiple cycles, not only once. There are cycles for that also. So here you do radical cystectomy plus adjuvant chemotherapy. But if you have removed the urinary bladder, then how does the person piss? So for him to micture it, he needs a new bladder, which is called as ileal conduit. Okay, you take a piece of the ileum, one end you bring out from the abdomen like an ileostomy, other end in which you put the ureters. So ureters go into the ileum goes to the abdominal wall. That is called as ileal conduit, and then you give chemotherapy. If it is going to adjacent organs, you will give neoadjuvant chemo. If it gets downstaged, then you can try surgery. Or you will have to do palliation. No, you can't. They have to give some clue. That recall is not proper. They have to tell whether it is muscle invading or not. Some clue has to be there. Otherwise, you can't decide the treatment. Enough. So, this is how you are going to do stage-wise treatment for bladder tumor. Straightforward. Okay. This is one of the most difficult cancers that students study. Now you won't make a mistake in this. Right. The role of radiotherapy, it's an alternate to surgery. Like for prostate, it's an alternate. But that should not be the answer in the exam. Exam answer should be surgery. Okay. Yeah, MVAC. Correct. MVAC. मालूम है, let's do this को पता है. बढ़िया. Okay. So now you come to bladder rupture. Very interesting topic. Very useful topic. And we will do bladder and urethra together. Okay. So it will become even more pristine and even more clear in your mind. Now you look at the bladder from the side. Okay, this is male bladder. You are seeing it from the side. In front of the bladder means here. This is anterior. This is posterior. Somewhere here is the pubic symphysis. Okay, this is pubic symphysis. The pubic symphysis has the abdominal wall skin over here. It has the abdominal wall muscles over here. And the last layer of the abdominal wall is the peritoneum. What is that peritoneum? The last layer of the abdomen. What is that peritoneum? What? No, scarpa fascia होती है. Scarpa. It's called parietal peritoneum. It is the peritoneum on the abdominal wall. This peritoneum goes like this on top of the fundus of the bladder. Behind the bladder in men is your rectum, like this. So this peritoneum also goes on top of the rectum. Okay, this is the parietal peritoneum. On top over here is my intraperitoneal cavity. So here are my intestines, omentum, small bowel will all be here. Okay, small bowel omentum above the bladder. Now, what keeps the bladder in place? What prevents it from falling down? Like here is going to be the prostate. What prevents the bladder and prostate from falling is this muscle. It goes like this, which suspends the bladder and the prostate, which also suspends the uterus in females, which also is going to suspend the rectum. Even the rectum is kept in place by this. Right, that is the pelvic floor, levator ani. Okay, so this is the basic orientation of the bladder. Bladder and things around it. What is this area called around the bladder? Above the pelvic floor, around the bladder. What is this plane called? It is called cave of Retzius or perivesical space. Okay, this is the basic anatomy you need to know when we talk about bladder rupture. Once we finish bladder rupture, we'll do urethral rupture. Okay, but this is the basic anatomy you need to know. Someone was asking about ileal conduit 2-3 times. See, not that important. I have removed the bladder. Now I am left with kidneys and the ureters. Now, where do I put the ureters? How will he pass the urine? This is the abdominal wall on the side. From the small bowel, I take a piece of the ileum. Okay, with the blood supply. I take ileum. I pull it out like this, like a stoma. On the other end, I implant the ureters. Okay, I close the end and I put the ureters in it. So whatever urine gets created will go out in this stoma. This is called a ileal conduit. Okay? This is ileal conduit. So see that page went and something has changed in my PPT only. Okay. You got ileal conduit. Now we go to bladder rupture. So this is the anterior posterior. This is the orientation of the bladder. This area around here is called as the perivesical space. Okay? Now, when will the bladder rupture? We are talking about bladder rupture. When will the bladder rupture? It will rupture when the bladder was full at the time of injury. We are talking about rupture during trauma. If the bladder was full and the person got a trauma here, bladder can rupture. So how does it rupture? Either the trauma comes little higher up, the force goes like this, it tears the bladder over here and the peritoneum over here. So bladder and peritoneum have burst at the roof of the bladder. So what will happen? The urine goes into the peritoneal cavity. This is called as intraperitoneal bladder rupture. Urine is going upwards into the peritoneal cavity. Sometimes the force of injury comes here on the pubis, where the bladder will burst over here at the side, not the roof. If it bursts over there, then the urine will leak here in this space, cave of Retzius. This is called as extraperitoneal rupture. So bladder rupture of two types. First type, intraperitoneal, where the urine is leaking in the peritoneal space. Here the part of the bladder which has burst, that is the fundus of the bladder. Fundus has torn. Urine is leaking intraperitoneally. There is an intraperitoneal leak. What is the effect of the intraperitoneal leak? If the urine is going in the peritoneal cavity around the intestines, what will it lead to? It will lead to peritonitis. So in IP rupture, peritonitis. In extraperitoneal rupture, it's very simple. Urine is leaking around the bladder. So that is not much of a problem. So in extraperitoneal rupture, lateral wall tears and the urine leaks not intraperitoneally, it leaks in cave of Retzius, perivesical space. No. This is nothing to do with penis. Penis scrotum नहीं है, मैंने बनाया नहीं है भाई अभी तक penis scrotum. Don't go there. That is some other condition. Here the urine is leaking over here. Levator ani के ऊपर, around the bladder. So here there is no peritonitis. Okay, here there is no peritonitis. Now, how will the person present in both the cases? Presentation is the same. He will have history of injury to lower abdomen. And he will say, since injury, since the bladder burst, unable to piss. So unable to micturate. Any patient after trauma who is unable to micturate what you should do first after doing the ABCD, after you've done all the basic things, you have to look at the meatus, and there should be no blood at meatus. If there is no blood at meatus, it may be a bladder rupture. Okay, so when the bladder will burst, whatever blood will be there will be around the bladder. It will not go in the urethra. So there should be no blood at meatus. What do you do in this case? How do you confirm your diagnosis? You insert a Foley's, inject the contrast into the bladder. Insert Foley's, inject contrast into bladder, and take an X-ray. Bladder rupture may you can catheterize. You take an X-ray. This X-ray is called as, don't say urethrogram. You are looking at the bladder. You want to look at the bladder. It is going to be a ascending cystogram. Okay, don't say urethrogram. You are not looking at the urethra. Bladder rupture, cystogram. It will look like this. You have put the Foley's, injected the contrast. Contrast is in the bladder, but here you can see some contrast leaking out. Okay, this looks like intraperitoneal rupture. In the photo, yes, likely to. So you have done a ascending cystogram. This will confirm whether it is intraperitoneal rupture or extraperitoneal rupture. Yeah, ascending and retrograde is the same. Ascending को आप retrograde भी बोल सकते हैं, but cystogram, don't say urethrogram. If it's an intraperitoneal rupture, means the person is having peritonitis, which means you have to do a laparotomy and repair. The perforation has to be closed. If it's an extraperitoneal rupture, you need to do nothing. Just keep the Foley's and let the rupture heal by itself. Usually by 8 to 10 days. Usually. You can leave the Foley's in place. But that's it. So the basic difference, why I need to differentiate the two, is for intraperitoneal rupture, there is going to be peritonitis. In extraperitoneal, yes, urine has leaked, no doubt. There is urine here. But this urine is sterile. Over time, it will get reabsorbed. It should not get infected. Should not. There is no reason. If you want, you can aspirate the urine, but you don't need to. अपने आप वो निकल जाएगी. Because urine is sterile and it will not be a lot of urine. 200-300 ml urine will be there. But urine in the peritoneum is a problem. Because there it will cause peritonitis. So that's the basic difference. That's why these two need to be differentiated. Okay, intraperitoneal and extraperitoneal. All right, you understood that? So for peritonitis, you clean the abdomen. Na? You open the abdomen, clean everything. It can cause theoretically, if the person is immunocompromised, it can cause. Otherwise, no. Theoretically, it can. Okay. If it does, then obviously you have to treat it. Bladder में stricture नहीं होता ना दोस्त. Bladder is a bag. Bag will not have a stricture. Stricture is in luminal organs, like a urethra, bile duct. वहाँ पे stricture होगा. Bladder में नहीं होगा. है ना? So that is bladder rupture. The second rupture, which is even easier to understand, is the urethral rupture. You understand, bladder, urethra is nothing. So urethra has two parts. One is this posterior, which is surrounded by prostate and the sphincter. Then you have the bulbar and the penile urethra. So this little curved urethra over here is the bulbar urethra, and distally it will continue as the penile urethra. Okay, now to continue penile urethra, this is the suprapubic skin which comes down, becomes the penis, and this penile skin comes back, becomes the scrotum. This scrotum goes back, this perianal skin. Here is the anal canal and the perianal skin. This is the full anatomy of the perineum. So this is the posterior urethra, prostatomembranous. This curved urethra is the bulbar urethra. This straight distal urethra is the penile urethra. Penile urethra में कुछ नहीं होता, जो भी होगा यहाँ पे होगा, either posterior or bulbar urethra. Now, how will this get injured? How does urethra get injured? Membranous is the urethra which is over here, between the pelvic diaphragm. Now, how does the urethra get injured? It can happen if there is injury over here, but the same injury caused bladder rupture. So, what will decide whether bladder bursts or urethra bursts? If the bladder was full, bladder will burst. If the bladder was empty, urethra will burst. So, if I have an injury in the lower abdomen, it can tear the urethra over here, prostatomembranous. Urine in this case will leak in this area. Not much urine will leak, not much, little bit, but it will leak in the same area, cave of Retzius. This is posterior urethral rupture. Sometimes injury can happen over here, perineum. Okay, perineum. If the perineum gets injured, it will cause an injury to the urethra over here, bulbar urethra. Then what will happen? Urine will collect in this area, in the perineal space, in the scrotum, in the penis. This is superficial perineal pouch. So, two injuries, very different. One injury will cause posterior rupture, one injury will cause bulbar rupture. And they are very different. They have no connection to bladder rupture. They normally have no connection. So, how will you get a urethral rupture? This can also be of two types. First is the posterior urethral rupture. This happens when there is injury to posterior urethra. Techno, deep perineal pouch and cave of Retzius is not the same. There is a membrane above the levator ani. That is the deep perineal pouch. Uske upar is cave of Retzius. Okay, but surgically not significant. So when there is posterior urethral rupture, this will happen when there is injury to pubis. And in this case, the urine will leak. Again in cave of Retzius. Sometimes when this happens, sometimes when there is a posterior urethral rupture, there is one ligament which attaches the prostate to the pubis like this. That ligament also breaks because of the injury. If that ligament breaks, the prostate does not get support. That is the puboprostatic ligament. If that breaks, you have a floating prostate. You can feel this on per rectal exam. Floating prostate, also called as Ver-Mouton sign. This is called as Ver-Mouton sign. So in posterior rupture, it looks like a extraperitoneal bladder rupture. Looks like it because the urine is leaking in the same place. The second rupture is the bulbar rupture. But this is very different because here there will be a perineal injury. What is it also called? Perineal trauma. How does someone get perineal trauma? It is called a straddle injury, also called as a fall astride injury. This word came in the FMG exam. What gets injured in a fall astride injury? Like on a manhole cover where you fall like this. That is called a fall astride. Horse riding is fall astride, correct? Sorry. So if this happens, the urine will leak around the perineum. Okay, the urine leaks in superficial perineal pouch. Okay, superficial perineal pouch. And from there, it will go into the scrotal skin and into the penile skin. Okay, so there is no confusion in urethral rupture, post-urethral rupture. There will be urine leaking into the cave of Retzius after a pelvic trauma. Perineal trauma, urine will leak in the superficial perineal pouch, subacute of scrotum, subacute of penis. Both are very different clinically. Now, how are they going to manifest? Any patient who comes with any of these injuries, after which he says he is unable to micture it. Because if the urethra burst, how is he going to piss? So he will be unable to micture it. But here, the golden finding is blood at meatus. If there is blood at meatus, his urethra is burst. And if there is blood at meatus, you cannot put Foley's catheter. Foley's catheter can't be done. So what will I do? I look for these findings. Is there a floating prostate? Is there a pubic trauma? Or is there a perineal trauma? Is there a perineal hematoma? I look for all that. But I want to confirm the diagnosis. Yeah, both. Urethral rupture, blood at meatus. Posterior or bulbar, it doesn't matter because the bleeding is in the urethra. The blood will come out from the urethral meatus. So to confirm, now I can't put Foley's. Okay, now I can't put Foley's. Now I put just the tip of Foley's at the meatus. Okay, just the tip of Foley's at the meatus. You can feel floating prostate, yes. And I inject contrast. Yeah, obviously, if you are putting Foley's and you inflate the bulb of the Foley's and then you see blood coming out, that means the urethra is burst. Okay, obviously it means that. So I inject contrast at the tip of the meatus and I take an X-ray. So I will see contrast going like this: penile urethra, bulbar urethra, posterior urethra, bladder. This is normal. But on the other hand, see the second image. Contrast is going. This is penile urethra. This is bulbar urethra, the curved urethra. But here, the contrast is leaking. This image is called as ascending urethrogram. Okay, don't call it cystogram. You can call it retrograde or ascending urethrogram. This will confirm the rupture. Remember, you're looking at the urethra. See, it is difficult to differentiate. I understand, even for me. And you are going to have radiology class tomorrow or day after. You can confirm how to differentiate. But I'll tell you what I use. नहीं, दोनों में bladder will be palpable. You want to know na whether it is bulbar or posterior. What I will say, curved urethra is bulbar urethra. Straight urethra is posterior urethra. But you should also look at the history that they have given, because they will tell you na perineal trauma, bulbar urethra, pelvic trauma or pubic trauma, posterior urethra. That history should be there. Image itself not very easy. Okay, so you do ascending urethrogram. This will confirm urethral rupture. Okay, this will confirm urethral rupture. Does it matter whether it is posterior or bulbar? Does it matter whether it is posterior rupture or bulbar rupture? No. Spongy is not a surgical word. Spongy means urethra inside the corpus spongiosum, means penile urethra. You've asked it 3 times. I don't know why. There is nothing surgical in it. Spongy means inside the corpus spongiosum. Now, if I see the contrast is leaking, what should I do next? I cannot put Foley's catheter, it is contraindicated. So what I do in this case, next step is called as suprapubic cystostomy. Okay, this is called as suprapubic cystostomy. It means this is the abdominal wall over here. I put a catheter directly into the bladder. Okay, directly. So above the pubis, I cut the skin, subacute muscles, put the SPC catheter directly into the bladder, and it is put blindly. Okay, it is put blindly. So SPC, since it is done blindly, the prerequisite is after bladder is distended. Okay, after bladder distends. This is a prerequisite. So you do SPC, urine will come out. His urination is taken care of. But obviously there is a tear over here. यहाँ कुछ तो फूटा है posteriorly या बल्वार में. उसका क्या? What about the tear? Okay, what about the tear? You do a delayed repair. So you wait for about 1 to 3 months. Let it form a stricture. And then you do a stricture repair. Okay, so the management is going to be suprapubic cystostomy followed by delayed reconstruction. Okay, at routine or emergency only. आपको क्या लगता है? This is routine or emergency? Let's do this. दिल से कहो, is this routine, SPC or emergency? दिल की नहीं सुनते हो आप यार, दिल की ज्यादा सुनते हो. Somewhere the thought process is not happening. Like someone is asking me difference between cystogram, urethrogram, micturating cystourethrogram. That is for ideology. I can teach it, but then when will I teach surgery if I teach you all that? And how long? For 1 to 3 months. It has to be there for 1 to 3 months. Okay. I'll tell you how to know stricture has formed by ascending uretherogram. Yes, you have to keep repeating imaging again and again every few weeks. Once you know the stricture is formed, then you do the stricture repair. Here, management is same as bile duct injury, chronic bile duct injury. It is the same. Yeah, acute, chronic. Some types of acute bile duct injuries were managed exactly like this. BCD. You did a delayed repair. Okay, so logic is the same, absolutely the same. Now, please understand. If you want to know what is uretherogram, cystogram, name tells you. Ascending means you have put the contrast from below. Okay, नीचे से contrast डाला है, so ascending. Uretherogram means look at the urethra. Cystogram means look at the bladder. When you say micturating cystourethrogram, that is the third thing that you wanted. MCU means you have to take the X-ray when the person is micturating. Now tell me, when he is micturating, how are you going to take the X-ray and how will the contrast go in the bladder? Which means to do micturating, you have to first fill bladder with contrast. Okay, you have to fill bladder with contrast. You can put it by putting a Foley's, or you can give it intravenously, and when the intravenous contrast has reached the bladder. So bladder has to be filled with contrast. Ask the person to urinate, and he has to urinate in the X-ray room. And while he is urinating, take X-ray. In process. It looks the same. It looks the same. Okay. Don't say, can I differentiate them by photo? Photo is the same. Cystourethrogram means you will see bladder and urethra. Now, whether it is ascending or micturating, it doesn't matter because you will see the same structures, unfortunately. But can I do MCU here in any of these cases? No, because the bladder will not fill if it is burst. Then how is he going to micturate? He came because he was unable to micturate. Micturate नहीं कर पा रहा था because bladder was burst or urethra had burst. Then how are you going to do micturating cystourethra? Right? यही बात समझ में? बस 2 कदम का लॉजिक लगाना है, उतना ही है. 2 कदम का लॉजिक. उतना लगाओगे तो रैंक आएगी, उतना नहीं लगाओगे तो कुछ नहीं आएगा. ठीक है, नहीं तो कुछ भी नहीं आएगा. Right? Is IV also real time? Yeah, it is real time. You have to take every few minutes. The exercise have to be taken every few minutes. ठीक है, हो गया, कुछ तसल्ली मिली? अब नहीं बोलोगे सर ने ये भी नहीं बताया. Okay, so now comes VIMP topic. Posterior urethra, same. No, posterior means prostatic and membranous, both together. If bladder is distended, then bladder will burst, not urethra. Okay, if bladder is distended, bladder will burst. How will urethra burst if bladder is distended? Okay, now urinary TB, most common site of urinary TB is the kidney. And how does it reach the kidney? It is a secondary spread. It is secondary from lungs via hematogenous route. So you have a primary in the lungs, it gets reactivated hematogenously from the lungs, it will go into the kidney, and in the kidney you will get the bacillus which will start causing the damage. So it's a secondary TB, extrapulmonary. Where does it reach first? First site, it is the glomerular vessels. Okay, it reaches the glomerular vessels. Now, when it reaches the kidney, what it will do in the kidney depends on the person's immunity. How much damage it will cause depends on the person's immunity. Either the person will have a poor immunity or he has a good immunity. Usually it will be poor immunity. If he has a good immunity, then what will happen when the bacteria reaches the kidney? These bacteria will start forming granulomas. You know, right? Those non-caseating or caseating granulomas with Langerhans giant cells. So you get the granulomas, they will undergo calcification because you have a good immunity. These calcified granulomas appear on X-ray like stones. That is why this is called as pseudocalculi. Okay, they look like stones in the kidney, but actually it is a type of calcification. They are calcified granulomas, so it is called as pseudocalculi. But if he has a poor immunity, then what will happen to the kidney? Then what will happen to the granulomas? Then these granulomas start first forming ulcers. So the first pathology in the kidney is you are going to get papillary ulcers. Okay, so सबसे पहले you are going to get papillary ulcers. That is the first pathology in the kidney. Over time, these ulcers will keep becoming bigger and bigger and bigger. They will start growing. And you start getting bigger lesions in the kidney. So big ulcers, very big. They are called as fibrocavitary lesions, like you get in the lungs, same way. So you'll get fibrocavitary lesions. And eventually, the entire kidney gets replaced by caseation necrosis. That is called as putty kidney or cement kidney. And while all this is happening, I don't know why, but patient does not know all this is going on in one of his kidneys. He is just going about living his life, just like you guys are. You have been going on with so much of things breaking inside you, but you're like, nee, kaam chalu hai. This is the stage where you come to know, oh shit, I don't know this, I don't know that. Otherwise, 1 साल, 2 साल, 5 साल से तो जी रहे थे. Same way, patient also lives with the bacillus, killing his one kidney. Because it's only one, now you have two. So now the kidney has become a putty kidney. This putty kidney or cement kidney eventually will explode and the pus or the caseation starts spreading outside. This will form what is called as a perinephric fistula. Okay, this will form a perinephric fistula. It will start coming out from the skin of the abdomen. Dhire, 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 dhire. Kidney is gone. It has gone outside the kidney. Perinephric collection, which goes outside the abdominal wall. Perinephric fistula. And while all this is going on, the bacillus is not just sitting inside your kidney. The bacteria will start going into the pelvic ileal system. And from the pelvic ileal system into the ureter. And from the ureter into the bladder. So just see how much and where all it is going. Slowly, 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 one at a time. Like from the kidney, it will start going into the cholecyst. That is called as moth-eaten cholecyst. Moth-eaten cholecyst is the first finding on imaging. So first site of TB, kidney glomerular vessels. First pathology, papillary ulcer. First imaging finding, moth-eaten cholecyst. From the cholecyst, it will go to the renal pelvis. It will start causing distortion of the pelvis. It will pull up the pelvic ileal system. So your pelvic ileal system gets pulled up like this. That is called as Kehr's kink. Okay, or pulled up, PUJ. Just like you had pulled up IC junction. Remember in ileocecal TB, IC junction was pulled up because of fibrosis. Same way here, PUJ is getting pulled up because of fibrosis. Then from there, the bacteria is going in the ureter. It starts distorting the ureter. So you get a lead pipe ureter. Okay, you get a lead pipe ureter. Also called as corkscrew ureter. Like you had corkscrew esophagus, here you have corkscrew ureter. But it doesn't stop there. It will just keep going from the ureter. Now it will enter the bladder. And first it will cause inflammation around the bladder. So around the bladder, the first finding is going to be periorificial edema. Periorificial edema. This is the first finding on cystoscopy. So one more first. First cystoscopic finding, periorificial edema. Eventually, the orifice will get distorted and you get a golf hole orifice. This came last year. So eventually you have a golf hole orifice. And then it will spread to the rest of the bladder. And you get a contracted or a thimble bladder. So just imagine how much this bacteria has done. Dhire, 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 dhire. Chabate, 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 chabate. Okay. So all your internal misdemeanors, जो भी आपने पाप किए हैं ना, ये उस सारे पाप का कर्मा है. Right? Started in the lungs, went to the kidney, slowly ate up the kidney, papillary ulcer, cavitary lesions, putty kidney, perinephric fistula, distortion of the pelvic ileal system, everything. Then full ureter, full bladder, can go to the contralateral ureter, goes lower down also. It doesn't stop here. From here, it will go into the urethra. You will get urethral stricture. So don't think it has stopped. It has destroyed your full urinary tract, urethral stricture, seminal vesiculitis, epididymoorchitis, everything. TB epididymoorchitis भी होती है. So it has destroyed your whole urinary tract slowly, 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 one day at a time. Okay. This photo that you are seeing here, this is from Bailey. which has all the points that I mentioned in an image. So all these words, moth-eaten calyx, care skink, putty kidney, ureteric stricture, pipe stem, corkscrew, gallful orifice, thimble bladder are all mentioned in this. So this is from Bailey, the current edition, and all the points that I mentioned are over here. Okay, this is the entire pathophysiology. Each of these points is an MCQ. Okay, every point here is an MCQ. This part is easy. The part as to how will the person present. He presents late, but he will present with usually increased frequency of urine because his bladder has become small, contracted, and he may have TB symptoms like low grade fever and all that. They may be there. But patient comes with increased frequency of urine. What will you do first? Urine routine microscopy plus USG, KUB. Urine routine microscopy will show pus cells in the urine, but there are no bacteria because you need to do special tests to identify the bacteria. So this urine is called as a sterile pyuria. Right? Sterile pyuria, urinary TB. पुटी किडनी नो 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 एक ही किडनी गई है ना दूसरी किडनी तो ठीक है ना TB quantiferon is not used here. TB quantiferon is used to identify people who have latent tuberculosis, not someone who has the full freaking urinary tract gone by TB. So it's not for diagnosing TB. It is for identifying latent tuberculosis. Here, a person has sterile pyuria. He has pus cells. You do USG QB. It will show some damage of the kidney. To confirm the diagnosis, you have to subject the urine by doing a centrifugation, the urinary cells, you will subject it for microbiological assessment, that is CBNAT and liquid culture. And ideally, this should be done on 3 consecutive early morning samples. Okay, 3 consecutive early morning samples. This is the diagnostic test for urinary TB. Okay, so ये करके आपको पता चल जाएगा. You can do some imagings, like you can do CCT abdomen. What image is this? What do you see in this first image? What is the imaging modality? Is it a plain X-ray or a IVU? This is a plain X-ray, KUB. It is showing calcified kidney. Could be a putty kidney. Could be. Okay, but I am only seeing calcifications. What is this image? You can see the ureters. And you can see a nice small bladder. So this is an intravenous urogram showing a thimble bladder. Okay, you can do cystoscopy in which you will see gallful orifice. And the treatment is going to be anti-tubercular therapy. Surgery is going to be done only if there are complications. But that's it, job is done. It is one of the most important topics in urology and one of the most misunderstood topics. But just see, it has a wealth of MCQs possible. So many MCQs can come from this. You understood it? How much ever they will twist, you won't have to worry about it. ATT in this case is going to be what you follow for extrapulmonary TB. But it will match pulmonary TB. Okay, cool. So we'll take a break now. Small break. Please be back by 7:20 p.m. Okay, 7:20 p.m. It is 2 plus 4 only for this. Okay, 7:20, please be back.
अंदर